Hi, and very good morning to all of you. It's my great pleasure in warmly welcoming all of you for yet another CPD webinar program organized by Shri Knowledge Academy. Today's our topic of interest is obstructive causes, obstructive jaundice in infancy. An interesting and also an important topic, a relatively common disease observed in neonates and infants. And our resource person is a distinguished personnel and a reputed consultant, Dr. Sanjaya Abeygunasekara, consultant pediatric surgeon, Lady Ridgeway Hospital, Colombo. Before we move on to the webinar, the lecture, I would like to humbly remind all of you regarding our housekeeping rules. The webinar link will be available until 9:45 a.m. for anyone to join in. No late attendees will be entertained thereafter. And each attendee should have been attended till the end of the webinar to obtain the e-certificate and the CPD points. And the CPD points, as you all know, are strictly adhered to the NCCPD guidelines. And this is to improve and maintain the status of the CPD programs conducted by the Shri. So thank you for your strict adherence of the CPD regulations and your kind complaints. I also would like to encourage you all to keep yourself on mute and switch off the video during the lecture. And for any queries and questions, please drop it in the chat box and also change the chat settings to all attendees and participants so that they can be seen and discussed towards the end of the webinar. So without further delay, let's get into the lecture. Over to you, dear sir.
Good morning. Thank you for your kind introduction. Today we are going to discuss obstructive jaundice in early infancy. So during the next 1 hour, we are going to talk about the incidence of jaundice and then the obstructive jaundice, and why is it important to differentiate obstructive jaundice from non-obstructive jaundice or non-cholestatic jaundice. And then we are going to talk why is it important to diagnose obstructive jaundice in the very early and not to delay it, and also how to formulate a differential diagnosis when you have a patient with obstructive jaundice. What is your differential diagnosis, and then we are going to discuss how to narrow it down, and then how to confirm the final diagnosis and how to treat it. And we are going to discuss the common causes of obstructive jaundice or the surgical jaundice, that is biliary atresia and cholestatic cyst, and touch on other causes as well. So we are going to start with the epidemiology. Now, as all of you know, jaundice is a very common, ubiquitous finding in the neonates. So much so that about half the neonates will have some form of jaundice, usually mostly physiological jaundice, and which will normally disappear by the second week of life, and it might last a little longer in the breastfed baby up to about 3 weeks. And on the other hand, conjugated hyperbilirubinemia, that is the cholestatic jaundice, is a rare entity, and which is about 1 in 1,000. So in other words, if you have 1,000 babies, 500 will have, approximately 500 will have physiological jaundice, that is mostly unconjugated hyperbilirubinemia, and only 1. So for every 500 jaundice patients, only 1 will be conjugated hyperbilirubinemia or cholestatic jaundice. But why is it important to differentiate this cholestatic jaundice from non-cholestatic jaundice? Because non-cholestatic jaundice is usually physiological and self-limiting, and you don't need to do much, and most people are aware of it. But on the other hand, cholestatic jaundice or obstructive jaundice, which is a much more serious condition, and usually will not resolve on its own, and will need serious intervention to cure these babies. So because of that, it is very important to differentiate, because non-cholestatic jaundice is commoner and is managed conservatively mostly, and very rarely needs intervention. If you miss the cholestatic jaundice amongst the large group of non-cholestatic jaundice, then there will be a delay in the diagnosis and with very grave consequences. So not only do you need to differentiate the two, but you need to do it without delay. So there is no point really diagnosing a cholestatic jaundice or differentiating a cholestatic from non-cholestatic at the end of 3 months. You have to do it within the first few weeks, or at least within 1 month, to prevent subsequent complications, and eventually sometimes it will end up in death. And why is it important to diagnose cholestasis early? Because biliary atresia, which is probably the commonest cause of obstructive jaundice, has the prognosis of the eventual prognosis depends on the age at which you operate. So if you operate on a baby with biliary atresia before 60 days, you have the best prognosis or best chance of surviving with that native liver. But if you operate it beyond the 3rd month, the prognosis is very, very bad, and you will eventually need a liver transplantation in those babies. And also, even other forms of biliary obstruction do well, because if you diagnose biliary obstruction early, then you can reduce biliary cirrhosis by various interventions. And even intrahepatic cholestasis, the outcome is better if you diagnose early, because then you can treat their bile salt deficiencies, these fat-dependent vitamin deficiencies, and eventually the coagulopathies can be treated, and vitamin D deficiency, which will eventually lead to rickets, and the others can be treated early. So all forms of cholestasis, whether it is intrahepatic or extrahepatic, needs to be diagnosed early to prevent complications and death. And so how do you do that? So to catch them early, so those who are jaundiced at 2 weeks, especially those who have pale stools and dark urine, which almost clinically confirms the diagnosis of obstructive jaundice, needs a bilirubin. So if you have jaundice with dark urine and pale stools, you need to do a bilirubin level immediately. But if it is jaundice beyond 2 weeks, still you need to do a bilirubin, the direct fraction. And you can delay it by about a week if the child is exclusively breastfed, because their physiological jaundice might last a little longer. But you should never reassure a child who has jaundice with dark urine and pale stools, because that child needs early investigations to find out the reason for the cholestasis. So what are these causes of obstructive jaundice or obstructive cholestasis? So the commonest cause of surgical jaundice is biliary atresia. Then you have choledochal cyst. Then you have an entity called inspissated bile syndrome, or biliary sludge, or stones blocking the common bile duct. Then you have biliary hyperplasia. That can be Alagille syndrome or a non-syndromic biliary hyperplasia. Then you have cystic fibrosis causing cholestasis. Then you have the neonatal sclerosing cholangitis and hepatic fibrosis or Caroli's disease. Okay, and that of course is merging with choledochal cyst. So what are these now? So we were talking about extrahepatic cholestasis, and what are the intrahepatic or hepatocellular causes of cholestasis? Now that's the commoner variety. So you have neonatal hepatitis syndrome, that can be due to toxoplasmosis, rubella, cytomegalovirus, herpes. So intrauterine infections can lead to neonatal hepatitis syndrome when the baby is born, and they can have cholestatic jaundice. It is very important to differentiate the two so that you can intervene early. And then you have other forms of severe bacterial sepsis causing jaundice. So it can be a severe UTI, sometimes severe sepsis elsewhere, And even syphilis, congenital syphilis, can cause a form of hepatocellular cholestasis or intrahepatic cholestasis. Then you have the metabolic or genetic syndrome, the alpha-1 antitrypsin deficiency, tyrosinemia, galactosemia, hypothyroidism, progressive familial intrahepatic cholestasis, and even panhypopituitarism will cause intrahepatic cholestasis. And then you have the TPN-induced cholestasis. So that can be mostly intrahepatic, but it can also predispose to biliary sludge formation or bile duct obstruction from biliary sludge. Then we will try to form a management algorithm for these patients. So if a baby is jaundiced at 2 to 8, in the first month or 2 of life, and if he is acutely ill, so if he has febrile illness or if he is unwell, then you have to manage the acute illness. Say if it is a UTI, severe pyelonephritis, you have to treat that and then reassess whether the bilirubin is corrected, or if there is any other infection, or if there is galactosemia, if there is tyrosinemia, then they can be ill due to the other effects of the illness, disease. Or if hypopituitarism, they can have other illnesses, so which is together with jaundice. So that has to be treated according to its own merits. And of course, if the direct bilirubin is high, but if the child is not ill or not acutely ill and just jaundiced but otherwise well, or you can all basically, you are seeing these children in an outpatient clinic, not in your emergency admission room, then you make a cholestatic diagnosis of cholestatic jaundice because the direct bilirubin is high. And then in those patients, then you obviously take a history and examine them and check the urine. And then if you find in your basic investigation there is galactosemia or hypothyroidism, then you manage the hypothyroidism or galactosemia accordingly. And if there is none of those, then you do your full blood count, the liver function test, alpha-1 antitrypsin levels, and an abdominal ultrasound. And if the abdominal ultrasound does show a dilated common bile duct and a cyst at the porta, like a choledochal cyst, then you investigate accordingly with a CCT or MRCP, and then confirm choledochal cyst, and then you proceed with definitive treatment, which is surgical excision. But if the choledochal cyst if there is no choledochal cyst, or if there is no dilated CBD or a cystic lesion at the porta, then a biliary atresia is likely. And then you will have other features of biliary atresia, which we will discuss later on the ultrasonogram. And then if you suspect it, then you can either confirm it with the percutaneous liver biopsy, depending on your the histology facilities, or your histopathological facilities has to be there to differentiate neonatal hepatitis from a biliary atresia. Then you can do a CT scan or HIDA scan, and also there is if you put a NG or nasoduodenal tube, and if you aspirate the duodenal contents, and if you demonstrate that there is no bile in your duodenal aspirate, then you know that there is biliary obstruction. Very, very rare centers, in 1 or 2 experimental research centers, they do neonatal ERCPs, where you need a special smaller caliber ERCP endoscope to do that. Then you can cannulate the duodenal papilla and then demonstrate that there is no bile duct but only the pancreatic duct. Okay, but for most purposes, the eventual confirmation of biliary atresia is by a per-op cholangiogram. So if there is delay in performing any of the above tests, then following ultrasound demonstration of the suspected biliary atresia, you can go on and do a cholangiogram and then confirm the diagnosis. And then if it is biliary atresia, then you proceed with the Kasai portoenterostomy. But if it is patent duct system or patent intrahepatic like neonatal hepatitis syndrome or biliary hyperplasia, then you act accordingly. So what is the serological evaluation of these babies with obstructive jaundice? You can do alpha-1 antitrypsin level, and if they are homozygous at the protease PI locus, then you can confirm your alpha-1 antitrypsin deficiency. And also the lipoprotein X is positive in all babies with biliary atresia, but it's also present in a small proportion of neonatal hepatitis syndrome. So therefore it is not a diagnostic. You can't positively confirm a diagnosis of biliary atresia, but if the levels are very high, usually about 300 milligrams, then you can, it suggests, or it's much more in favor of biliary atresia than a neonatal hepatitis. Similarly, gamma GT is elevated in biliary atresia, but it can be elevated in other conditions of hepatitis as well. So there has to be like a cutoff mark, which is about again another 300 international units per liter. So if a gamma GT is below that, then biliary atresia becomes a little unlikely, but you can never kind of confirm your diagnosis by either of these tests alone. So the next investigation is an ultrasonography of the abdomen, and you have to do it, you have to send the baby to the radiology department with the baby fasting for probably about 3 hours, 2 to 3 hours. And so they do the ultrasound, then look at the gallbladder and the porta hepatis, and then if the gallbladder is full, then you feed the baby and repeat the scan, or the so-called postprandial scan. And if the gallbladder is emptied, then you know that the gallbladder is full and emptying as well. So that's evidence of a patent common bile duct. But if there is just a gallbladder which is there all the time and it doesn't empty on feeding, then that does not rule out biliary atresia. Okay, and also the normal gallbladder is about greater than 1.5 centimeters in length, and in the biliary atresia usually it's fibrotic and very atrophic. And also absent fibrotic gallbladder with a triangular cord sign, that is due to the fibrous bands at the porta hepatis, is very specific for diagnosis of biliary atresia. So the triangular cord sign is an invaluable finding in ultrasonography to confirm biliary atresia, and that is sufficient evidence enough for you to proceed with the per-op cholangiogram and then Kasai portoenterostomy if confirmed at the per-op cholangiogram. And then also now in these ultrasonograms, sometimes you might see a cystic lesion at the porta hepatis. Now that can be choledochal cyst, but it can also be rarely a entity called cystic biliary atresia. So in cystic biliary atresia, you can have a little cyst at the porta hepatis, but it is not a choledochal cyst. So this shows on per-op cholangiogram, this shows that there is a little cyst. The contrast is feeling a little cyst, and that's not going down towards the duodenum. It's at the porta hepatis, and this is not a choledochal cyst but a cystic biliary atresia. The importance of differentiating the two is that the cystic biliary atresia has a much worse prognosis when compared to a choledochal cyst, which once excised and a biliary enteric anastomosis is done, is usually cured of the illness. So because of that, it is important to differentiate that preoperatively so that you can discuss prognostic fact, you can prognosticate the illness, and you can discuss with the parents about the options available. So it is important to differentiate, because the prognosis is one is dismal, whereas in the other it is very good prognosis. And this is that same patient, the untable dissection. And so apart from ultrasonography, you can do a hepatobiliary scintigram, which is usually a HEDA scan, and that will show the uptake of the HEDA in the liver, and also how is it excreted in the bile ducts and into the gut. So if you see all three, uptake, normal, regular uptake, and excretion into the small bowel, then you can safely confirm that there is a excretory system, or the common extrahepatic biliary tree is properly developed. But if there is no uptake, then either the liver is very badly injured by the progressive cholestasis, or it can be an intrahepatic cholestasis that causes it. So then there won't be isotope in the gut. So for you to really confirm biliary atresia, you have to have a good uptake by the liver, uniform uptake, and then absence of isotope in the gut. But if there is patchy uptake or absence of uptake, then that indicates that the liver is pretty bad, and then it could be very well be a neonatal hepatitis or any other cause of cholestasis. Okay, and to improve the accuracy of the scintigram, you can treat these babies with 5 milligram per kilogram per day of phenobarbital, and that will induce the enzyme so that the isotope is excreted more effectively. So if the initial image shows no isotope in the gut, you certainly have to take a 24-hour film to confirm that there is no isotope at the end of 24 hours as well. So sometimes these isotope scans can be very misleading and can be misinterpreted as well. So for example, now this is a patient, of course it's an old scintigram. So we got this patient who had fairly typical features of ultrasound findings and others of biliary atresia, and we got a scintigram done because this baby was under 2 months at the time, so we had a little bit of time to confirm with scintigram. And the scintigram was reported as no evidence of biliary atresia because they thought there was isotope in the gut. But now if you look at it carefully, so you see that the liver is taking up the isotope very well, and then there is some amount of isotope outside the liver also. So this could be the bowel, or it could be the urinary bladder, because if it is not excreted in the bile, then it is goes into the eventually the isotope is excreted in urine. And so this delayed films also shows the same thing, and in a subsequent film that there is a lot of like diffusion of the isotope, which appears as if it's in the abdomen and was reported as bowel. But because this patient clinically and ultrasonographically looked biliary atresia, we were wondering whether this film shows isotope in the bladder, and the subsequent film is that the baby has emptied the bladder into a diaper, so that the isotope is in the diaper rather than the bowel. So we got them to repeat the imaging or the isotope scan, and now here, so we got them to remove the diapers and then fed the baby, and then eventually it was confirmed that the isotope actually was in the bladder, and then once the baby empties the bladder, there was no isotope at all in the gut. So it confirmed the biliary atresia, and then we proceeded with the photointerostomy. So just don't rely on the report of a particular test, but you have to learn to interpret the individual images also before you make your eventual diagnosis. So then finally findings are compatible with biliary atresia. So The other disadvantage of biliary scintigrams or liver hepatic scintigrams is that it can sometimes take weeks or months for it to be done, particularly in Sri Lanka, especially if there is delay in import of these isotopes, which is not manufactured here, then there can be huge problems. So because of that, one should never delay the eventual cholangiogram or subsequent portoenterostomy just because you are waiting for a scintigram. So if the investigation should never go beyond the second month, so if there is a delay beyond the second month, the final confirmation can only be done by doing a perp cholangiogram. So there is no excuse for delaying completing the sequence of investigations just because there is a delay in the scintigram. So the scintigram is not an essential part of your the investigative the pre-op investigations. So a liver biopsy sometimes is useful preoperatively, like a true cut biopsy to confirm the thing, but majority of the surgeons are not very keen on this because sometimes the differentiation of biliary atresia from other forms of biliary obstruction is difficult, and you will have ambiguity at the end of biopsy as well. So, and it's a little risky in doing biopsies, particularly true cut biopsies in these babies with coagulopathies. So only very rarely in a few centers where there is very good histopathological backup that you can do them. So, but just to go into the differentiation of the two conditions, so the main difference in biliary atresia versus other biliary obstruction is between the lobes or lobules of the liver. So in other words, the interlobular changes are the important changes in differentiating biliary atresia from neonatal hepatitis syndrome. So neonatal hepatitis syndrome otherwise has similar changes within the lobule. So there can be bile duct plugs, giant cell transformation, fibrosis, all those things in a neonatal hepatitis, but there is no ductular proliferation. So between the lobules, where they are near the portal triads, you will see the small duct proliferation of bile ducts, small microductules, and that is the characteristic feature of biliary atresia, and it will not be seen in neonatal hepatitis syndrome. And a little bit of the history of how to treat, how the treatment of biliary atresia evolved. So in 1892, Thomson is the person who first described or designated biliary atresia as a specific disease entity. Until then, it was all grouped together as jaundice patients. So he first demonstrated that there is this entity where there is biliary obstruction due to absence of extrahepatic biliary tree. And then in 1916, Holmes derived the concept of correctable versus non-correctable biliary atresia. So correctable biliary atresias had a patent porta hepatis or patent hepatic ducts or patent common hepatic duct, and the biliary atresia was limited to common bile duct. So in those patients, a hepatico-jejunostomy corrected the problem, and it was very good results in the correctable one. But unfortunately, only about 10 to 12% of the babies have that correctable variety of biliary atresia. The non-correctable ones were destined for doom those days. So, but in 1928, Lads performed the first successful surgery for correctable biliary atresia. But in 1957, Kasai was the first one to describe portoenterostomy for the so-called non-correctable. So even if the biliary atresia extended up to the porta hepatis, where the intrahepatic or the hepatic ducts, common hepatic duct, plus or minus the common bile duct, if they are atretic, Kasai showed that if you do a portoenterostomy, the cholestasis gets corrected in a certain number of patients. And of course, in 1963, Stasel introduced liver transplantation as a form of therapy for biliary atresia. Usually, those who do not survive or are not anicteric following a portoenterostomy, liver transplantation was offered to them. But of course, there are few centers who offer primary liver transplantation for those who come beyond the 3rd month of life. But majority, or the great majority of pediatric surgeons believe that you should offer portoenterostomy at any age, and then that is a temporizing measure so that you can eventually do liver transplantation if your portoenterostomy doesn't work, because that will give you a few years to find a donor and a sizable child for a successful liver transplantation, rather than a small neonate undergoing a liver transplant. So just a few facts about biliary atresia. Its incidence is about 1 in 5,000 in the East or the East Asia. So the commonest incidence in biliary atresia is among the East Asians, the Japanese, the Taiwanese, the Chinese, but it is relatively rare in the rest of the world, especially in the Northern Europe. It's about 1 in 20,000. We do not know exactly the incidence of biliary atresia in our country, and it is high time that we form a biliary atresia registry, or so that everybody who operates on biliary atresia in Sri Lanka, if they make a single registry, then we will be able to say how many biliary atresias do we have a year. And the biliary atresia is usually classified according to types depending on the most proximal level of atresia. So if the atresia is the most proximal level of atresia is at the common bile duct, so from the duodenal papilla up to the opening of the cystic duct, if there is atresia in that segment, then it is called a type 1. So it becomes, so that means the hepatic ducts and the common hepatic duct is patent. So that becomes a correctable biliary atresia. The small 12% or the so-called 12% of correctable biliary atresia, that was the name given earlier. Now there is, it's not a big, you don't differentiate it like that. But so type 1 atresia has good prognosis. It can be corrected by a hepaticoenterostomy, and but only, unfortunately, is a minority. About 12 to 15% of patients have type 1. So type 2 atresia is atresia at the common hepatic duct. So the most proximal atresia is common hepatic duct. So you might have a patent CBD, or most of the time it is also atretic, but the hepatic ducts are patent. So again, it is a form of correctable biliary atresia. And then you have the type 3, which is the commonest, about 80 to 85% of patients, and the atresia extends up to the common, the portohepatis. So the hepatic ducts are atretic, common hepatic ducts are atretic. The rest of the system can be patent or maybe atretic as well. Okay. And also, so you can divide them according to subtypes A, B, C by the pattern of ducts, the intrahepatic ducts. So if you have a patent common bile duct, which is about 20%, so you can have a patent common bile duct in 20%, 1/5 of patients, patent common bile duct and the gallbladder, so that those patients have atretic common hepatic ducts and the hepatic ducts. So they are incorrectable variety, belongs to the incorrectable variety of biliary atresia. But when you do a cholangiogram, so if you inject contrast into the gallbladder, those patients will demonstrate isotope, the contrast material in the duodenum. Okay, so it is very important to know that, because those patients, just because when you inject isotope, when you inject contrast into the gallbladder, and if you demonstrate isotope in the duodenum, that does not rule out biliary atresia. I have seen that being done occasionally. So you need to demonstrate the common hepatic duct, hepatic ducts and intrahepatic ducts to be patent before you rule out a biliary atresia. So if any of those, the hepatic duct or the common hepatic ducts are not demonstrated on a cholangiogram, then you have to think that it's a biliary atresia. So that you can do by tilting the head down during the cholangiogram, and also you can clamp the common bile duct and then inject. So then if there is patent common hepatic duct and the hepatic ducts, then it will flow back into towards the liver. And in about 6% of patients you will have a fibrous common bile duct, and in about 14%, in 63% of babies, common bile duct is fibrous, and in 14% there is aplasia. So there is no common bile duct at all, just nothing. So, and you divide them again into subdivisions in Greek numerals, and that is the hepatic radicals. So if you have dilated hepatic ducts, so if you have atretic extrahepatic but dilated hepatic ducts, then you call them it's alpha, type alpha, and about 5% of patients. About beta is hyperplastic hepatic ducts, then gamma, then bile leaks, okay, bile lakes, and mu, fibrous hepatic ducts.
Hello.
Is fibrous mass, and omega is aplasia of the hepatic ducts. Okay, so there is absence of hepatic ducts. This is also a schematic illustration of the biliary atresia classification. So type 1, where it is the common bile ducts is atretic, and then type 2, the hepatic ducts atretic, common hepatic duct is atretic, but the hepatic ducts are patent, and type 3, which is there is atresia at the porta hepatis. Okay, but in that last one you can see that the common bile duct and the gallbladder is patent, so that when you inject stuff, it will go into the duodenum. Biliary atresia is not a single entity, because majority of them are isolated biliary atresias, true, but then there are certain patients who have other syndromes. So there can be syndromic biliary atresia and associated malformations. Then you can have cystic biliary atresia that I showed you earlier, and also there is a cytomegalovirus associated biliary atresia as well. And the majority, of course, are isolated biliary atresias. And the syndromic ones, and so associated malformations, then you can cystic, yeah. So the syndromic biliary atresia has, the commonest one is polysplenia, which is about 7%. And the patients with polysplenia also have other anomalies, associated anomalies in them, like a preduodenal portal vein, midgut malrotation, situs inversus, and associated maternal diabetes also. And certainly the syndromic biliary atresias have a poorer outcome. So this is a patient with the X-ray of a patient with situs inversus with polysplenia and syndromic biliary atresia. And the standard treatment, or the standard treatment world over for biliary atresia at the moment, is a Kasai portoenterostomy. So a rule loop of bowel is brought and anastomosed to the porta hepatis. Okay, and it has to be done before the 3rd month of life. It certainly is not the ideal solution, but there is nothing even closer. There is not even a close second best to Kasai portoenterostomy at the moment. So that's why every baby at the moment has to, with biliary atresia, a Kasai portoenterostomy is attempted as the first treatment option. And Kasai portoenterostomy is not just attachment of a rule loop of bowel just to the porta, just indiscriminately, but you have to dissect the entire porta hepatis and demonstrate the full extent of the porta, so that your rule loop covers the most possible points of these rudimentary or microductules of the hepatic ducts, intrahepatic ducts into that rule loop, so that the biliary drainage is optimized. Because if you just attach a rule loop to the porta hepatis just for the sake of it, it's never going to work. So your dissection should continue like that. So that's the fibrous remnant of the biliary atresia, and so you go along that plane and then down to the level of the portal vein. So you have to loop the portal vein, pull it down, and then you dissect it right up to that level and to this edge of the porta hepatis or the biliary plate. Okay, so because that's where the posterior wall of your rule loop should go, and need to be stitched here. So if you just stitch it somewhere there and the anterior wall there, that's not going to drain bile. Okay, so that is why it is important to fully deliver the liver outside. So can you see, we mobilized the liver and brought it outside completely, and you can see the porta hepatis pretty easily now. And so this here, the mosquito is holding the atretic gallbladder. Now we have dissected the atretic gallbladder off the liver, and then now here we have so this is the liver, then this is the duodenum somewhere here, and that's the left hepatic artery. So this is the right hepatic artery, and you can see it a little bit more clearer now. So that's the right hepatic. These are the left hepatic arteries, so the common hepatic somewhere there. Yeah, now we have mobilized the portal vein. So this is the portal vein coming from under the duodenum, and now the left branch of the portal vein. So this is like a T junction. So the left branch of the portal vein, and this is the right branch of the portal vein, and these are the left hepatic artery, and this is the left hepatic artery, and this is the right hepatic artery. Okay, so you got to isolate them, dissect them up to their divisions, and also so you pull the portal vein down and then dissect the back of the porta hepatis. So unless you do that and bring your rule loop here and then do a very wide portoenterostomy, they're not going to drain bile. So again, another patient, the same scenario. It's a little darker here. So you tape the portal vein, the hepatic arteries, and then you proceed with it. Again, another one. So there again you can see the portal vein there, and then this is the left hepatic artery, this is the right hepatic artery, and then you pull them down and then bring in the bowel loop and anastomosis it. Again, another one. And this patient now, this is this so-called wide bile. So sometimes the gallbladder is full and has a lumen, and ultrasonically they'll say there is a full gallbladder. But now this is just mucus in the gallbladder. There is no bile because there is no connection with the intrahepatic biliary system. But these patients sometimes can have a so this particular patient probably didn't have the CBD also was not patent, so it was just the bile formed by the mucus glands in the gallbladder itself, and so it's very crystal clear white thing. So as you see this, you know that there is a obstruction and the bile is not draining into the gallbladder. So all these patients usually are given ursodeoxycholic acid 25 mg per kg, high dose vitamin A, D, E, K, and also antibiotic prophylaxis. That is following portoenterostomy. And we also start this pulse therapy with methylprednisolone 2 milligram per kg per dose, a high dose to start off, and then every few days you taper it down, half the dose, and then eventually tail it off completely at the end of about 3 weeks. So the post-operative complications following a portointerostomy are cholangitis. That's one of the commonest ones because there is very little flow down the rule loop, so bacteria can colonize the loop. And the only measure that you can do to reduce the incidence of cholangitis is to have a really long rule loop, which is about 50 centimeters. Antibiotic prophylaxis sometimes helps, and also once you diagnose cholangitis, you have to obviously treat aggressively with IV antibiotics. So portal hypertension and esophageal varices is a result of inadequate clearance of jaundice and persistent obstruction and eventual biliary cirrhosis. So you can ban them, inject them, and if they bleed acutely, then you can start them on somatostatin or vasopressin, and you can also put them on prophylaxis with beta blockers. So you have newer varieties of beta blockers than propranolol, so you can use them, and also some of them end up with ascites. So the prognostic factors is that the age at Kasai is the single most important determinant. So if you operate them before the 90th day, preferably before 60 days, then prognosis is best. Beyond 90 days, it's progressively becomes low and low. And also, these are not surgeries for the occasional surgeon. So the one who encounters 1 or 2 biliary atresias a year should never attempt biliary atresia or portoenterostomy. So it has to be done in a unit where at least about 8 to 10 procedures are done a year. And the liver histology, when you look at them, and if the ductules are more than 300 micrometers, then the prognosis is distinctly better than if they are less than that. So the usual outcome after Kasai procedures is the clearance of jaundice is seen in about 50 to 60% of patients within a month or two of the surgery, and the 10-year survival of the native liver is about 40 to 50%. But overall survival is about 90% at the end of 10 years, because some of those with chronic liver disease also is going to survive, but they will be quite sick. So those who clear their jaundice within a week or two of portoenterostomy will do the best, and majority of them are alive and well with their own livers. So again, the age at Kasai and the thing. So these are some of our results that the Kasai portoenterostomy done in between 2015 and 2019, and so this is age-at presentation. So now these patients have presented to the doctors or the primary care givers, the pediatricians, the general practitioners. So majority, 16 out of the 19 patients presented to the primary care practitioner before the 30 days, and all of them have presented before the 60th day. So the patients have actually come to the doctors because they knew that these children are very, very jaundiced and it's going beyond the normal range, normal age physiological jaundice. But now the age at operation is only less than only about less than quarter of the patients have undergone the procedure before 60 days. That is because the surgeons have not got these patients. So there was a delay between the primary caregiver and the surgeon. So that is very unacceptable, because it is not because the patients don't present, but it is because the patients are not referred to surgical units in time. The majority of them have been waiting for the investigation results, and so they come to the clinic, they get their investigation done, and then they go back, and then they come back. So I think the obstructive jaundice should never be investigated as an outpatient setting, because in our system, patients have to travel long distances, they have financial difficulties, so, and also these results don't come, so the patients come to the clinic and then they find that the results are not there, so they are repeated or they are lost or whatever, and then there is eventual delay, and also waiting for these isotope scans will definitely waste time. So there is no point really investigating them. I think all those patients who have extrahepatic biliary obstruction, those who are not intrahepatic obstructions, should be investigated, preferably by the pediatric surgeon themselves, and then operated there, then investigated. Certainly should not investigate beyond the second month in a pediatric unit. It has to be in the pediatric surgical unit. So again, the success of the clearance of jaundice is very high if it is before the third month. So the overall survival is 68%, but the overall survival with the patient's own liver, native liver, is not very good. So the way forward is, the most important thing is increased awareness among the healthcare professionals, even more than among the general public, because the general public seems to be coming to the primary caregiver, but there is a delay, either because it takes longer for investigations, or patients are reassured and sent home saying, this is just jaundice, physiological jaundice, and you will get better. So then they come back really in a poor state. So where increased awareness among the medical professionals is a very important step forward in reducing the mortality and morbidity of biliary obstruction. And also prompt surgical referral, obviously, and also maintaining biliary atresia registries, and then you can give a feedback to the primary care givers, and also you can maintain where the biliary atresia is properly treated. And also development of subspecialty, especially pediatric hepatobiliary surgeons, pediatric gastroenterologists, pediatric hepatologists, pediatric nutritionists. So it's a teamwork. So biliary atresia certainly is a multidisciplinary team effort. And for the best results, you need all members to be involved in managing these patients. And a little input on congenital biliary dilatations, the so-called choledochal cysts, and usually these are supposed to be associated with pancreaticobiliary malunion, PBMU in short. That is, if the pancreatic duct is not opening in the normal way into the common bile duct. So, and also if there is pancreatic reflux of pancreatic enzymes or pancreatic juice into the common bile duct, people think that biliary dilatation or choledochal cysts is a secondary phenomenon. And usually they are presented as an incidental sometimes finding, or antenatally diagnosed large cyst in the porta hepatis, or in the investigation of some abdominal complaint, like a baby crying, constant crying, or jaundice or abdominal distension, and ultrasound scan is done, and then you find the choledochal cyst. So there are basically two types: one that presents within 1 month and within the first 3 months, and with obstructive jaundice, and the adult form, which usually they present beyond the second year of life, and usually they have abdominal pain, intermittent jaundice, or sometimes abdominal distension or mass palpable. The classification is very straightforward. So you have the type 1, which is like a fusiform dilatation. Type 2 is a saccular dilatation of the common bile duct, and type 3 is a choledochal seal, that is dilatation in the duodenal wall, in the ampulla area, or you have the intrahepatic and the extrahepatic dilatation both, and the Caroli's disease, the type 5. So this is one of the patients that we got. Massive cyst. Majority of the abdominal wall cavity was occupied by these choledochal cysts, one, on both sides of the abdomen. And here another the CT scan showing the same picture. And this child has had the excision of the choledochal cyst attempted by another unit, and then when they removed part of the large cyst, but then they lost the anatomy and they couldn't proceed, so they left Foley catheter in the remnant, the cyst remnant, and then closed the cyst around the Foley catheter, and then we got this patient some time back. So we did a cholangiogram or through the Foley catheter, and that shows that the residual in this one, yeah. So that's the Foley catheter, and that's the residual cyst, and you can see that this is the common hepatic duct. These are the hepatic ducts and the common hepatic duct. I think the gallbladder had been removed at the previous surgery, so these are connected. So we removed this residual gallbladder choledochal cyst, and then we did a rule loop onto this common hepatic duct, and then the baby who was originally with dark yellow jaundice, then is now quite white in the eyes and completely cleared of jaundice. Another cholangiogram of done on table for a choledochal cyst, and that's what you do eventually. And this is also a resected specimen of a choledochal cyst. And come to the end of the session, and thank you for your patient hearing.
So thank you so much, sir, for that informative and very insightful lecture. That really did shed some light on today's topic, which is obstructive jaundice in early infancy. And we have got few questions from the audience, sir. So getting onto them straight away, sir. The first question is, hello, sir.
Yeah, can you hear me?
Yes, sir. We can hear you, sir. So the first question of today's webinar is, what is the best diagnostic to do in an infant presenting with obstructive jaundice to come into a diagnosis?
Yes, as we said, initially we had to differentiate the obstructive from the usual physiological jaundice or hepatocellular jaundice. And once that is done, then ultrasound would, lead you whether there is a choledochal cyst or whether it is whether the features of biliary atresia, that those are mainly the absence of gallbladder and positive triangular cord sign at the porta hepatis. So if these are positive, and also when the baby is fasting for about 2 hours, baby is not fed for about 2 hours, and if you do ultrasound and if the gallbladder is not shown, then it is highly suggestive of biliary atresia. But if the gallbladder is full, or if you see a gallbladder when the baby is fasting, then you feed the baby and see whether that gallbladder empties. If the gallbladder empties on feeding, then there is a good chance that the baby doesn't have a biliary atresia, but it does not rule it out. And probably a single best, the investigation that we rely on is intraoperative cholangiogram. That is a very invasive procedure, but so if the investigations are dragging on and certainly beyond the second month or 60th day, then we would go for this cholangiogram, and then on table we make a decision, and that is pretty straightforward. The on table decision on with the help of a cholangiogram, and then once that is confirmed, then we will either go ahead with the Kasai photointerostomy if it is confirmed biliary atresia, or if biliary atresia is not shown. If the extrahepatic biliary duct system is patent, then we would, the procedure ends there, and there is no further dissection of the porta. The cholangiogram itself is done through a small incision in the right hypochondrium, subcostal incision, and then we would do the cholangiogram. So so that would be the single best test. But then all these other tests that we described earlier also will help. Yes. Okay. Is that clear?
Okay, sir. Yes, sir. Thank you, sir. Very well answered. And we got one more question, sir. Can total bilirubin be normal with increased direct fractions in a patient with obstructive jaundice?
No, usually it'll have to be, the significantly, the those who have biliary atresia or choledochal cyst with obstruction usually have very high. They are not, just a few nanograms, but they will be definitely in the, hundreds or high, the double-digit figures like 80. So, bilirubin, conjugated bilirubin level of less than 1 milligram or maybe 0.5, something like that, but it is above the theoretical mark by itself will not qualify for extrahepatic biliary obstruction. Those who come to us with extrahepatic biliary obstruction, like the biliary atresia, the choledochal cyst, the sludge will have much higher levels. But theoretically, yes, you can have a bilirubin, direct bilirubin, which is just above the cutoff mark, but the total bilirubin might not be very high because the indirect fraction is low. So, but those are unlikely to be, if it is a, say, 1 week old baby, yes, but beyond the second week, the direct bilirubin will really skyrocket if there is true extrahepatic biliary obstruction. But if intrahepatic cholestasis, yes, maybe it might not be very high initially, but again, beyond the second, third week, it'll really go up. Yes.
Well, sir, thank you so much, sir. And we got one more question here, sir.
Okay.
How widely is LEDS procedure offered for correctable biliary atresia or Kasai potorenterotomy? Is the preferred in those patients as well, in the patients with correctable biliary atresia?
So what was the procedure earlier? So Kasai potorenterotomy, and what is the other one?
And LEDS procedure, sir. Is
LEDS
how widely is
procedure
LEDS
is
offered
completely
to?
different. Yes, so LEDS procedure is a completely different operation that we do for midgut malrotation. So that is not
Okay,
a procedure for biliary atresia. The biliary atresia, the initial operation that needs to be done is photoenterostomy, where you bring a loop of bowel, preferably a roux loop that is, like a proximal jejunum. A loop of proximal jejunum is brought and then anastomosed to the porta hepatis, covering all possible draining points of the biliary remnants, which are quite small ductules at the porta hepatis. But LEDS procedure is performed to correct, it's the procedure done for a baby with a midgut malrotation, which is a completely different entity. Yes, not so LEDS procedure is not done for biliary atresia. Yes.
Okay, all right, sir. Sir, the last question for today's session, due to time concerns, could inspissated bowel syndrome be caused? Yeah, that could be caused due to cystic fibrosis, or both of them are separate entities?
Yes, a lot of the time the cystic fibrosis has, because of the lack of these enzymes, the bile becomes very thick and sludgy. So inspissated bile syndrome can be quite a large proportion can be due to cystic fibrosis because there is mucoviscidosis or thicker substances. So you can have cystic biliary obstruction like a sludge formation, or you can have these meconium ileus, and all those conditions are commoner in the cystic fibrosis. But fortunately, in our part of the world, it's less common than in the European countries. So cystic fibrosis is still not very common because the gene is not found in our part of the world. Yeah.
Okay, thank you, sir. Thank you so much. Those are the questions for today's session, and thank you once again, sir, for your wonderful lecture and clear
Thank you very
explanations.
much.
And yeah, sir. And thank you once again for your precious time, sir. So thank you once again for the participants, for your participation, and for your patience hearing. And we hope to meet you again in similar webinars in near future. And for the e-certificate and the CPD points, please follow the link which is shared in the chat box. Thank you and good day to all.
Thank you. Thank you.
Thank you. Thank you, sir.